Hi, my name is Francisco Murillo. I'm going to talk about balancing the risks and benefits of dual platelet inhibition. Definition: an antiplatelet drug is a member of a class of pharmaceuticals that decrease platelet aggregation and inhibit thrombus formation.
In a first step towards clot formation, platelets are recruited to the site of vessel injury by now exposed molecules of the vessel wall, such as collagen and von Willebrand factor. This factor mediates the linking of platelets to collagen via a specific receptor in the platelet membrane. The resulting change of shape of the platelet from its resting state into the dendritic form indicates activation. The activated platelet in turn releases prothrombotic molecules such as adenosine diphosphate, ADP. By binding to its receptors, ADP induces aggregation. And recruits further platelets to the site. Thromboxane is another important mediator of platelet activation and aggregation. Under its influence, the platelets cross-link with each other. These interlocking mechanisms cause platelet activation to snowball. The clot grows rapidly. Activated platelets also trigger the coagulation cascade and thus the formation of thrombin. Thrombin, in turn, stimulates platelet activation even further, a continuous feedback loop. Additionally, thrombin induces the formation of fibrin for the mesh stabilizing the clot. The self-reinforcing process of platelet activation, crucial in the formation of blood clots, is an obvious therapeutic target in conditions caused by inappropriately triggered blood coagulation.
Application in medicine. They are widely used in primary and secondary prevention of thrombotic, cerebrovascular, and cardiovascular disease.
Platelet adhesion and aggregation. In flowing blood, red cells predominate in the axial stream, while the biconvex disc-shaped platelets are marginated along the vessel wall, where they are well positioned to monitor the integrity of the endothelium. The normal endothelium provides a non-adhesive surface to circulating platelets. However, when vessel wall injury occurs, for example by cutting or severing of a vessel, or as shown here by a puncture, and there is endothelial damage, the initial response of platelets is that of adhesion to collagen fibers in the exposed subendothelium. Collagen is one of the most thrombogenic components of the subendothelial matrix, responsible for the initiation of platelet adhesion. A number of adhesive receptors on the platelet surface membrane interact either directly or indirectly with collagen. Initial binding of platelets is considered to occur via the integrin alpha-2 beta-1 GP1A2A receptor, which allows for further binding to collagen via the GP6 receptor, initiating transmembrane and subsequently intracellular signaling. Adhesion of platelets to the exposed subendothelium is influenced by shear rates. At high shear, alpha-2 beta-1 and GP6 are not sufficient to initiate binding to collagen, and binding of the GP1B95 receptor to von Willebrand factor, abbreviated here as VWF, that is immobilized on collagen, becomes essential in platelet adhesion. Platelet adhesion at the site of vessel wall damage initiates activation events that result in aggregation. Adherent platelets undergo a dramatic shape change to an irregular sphere with multiple filipodia spreading on the subendothelium, increasing their area of surface contact. Adherent platelets also secrete or release the contents of their storage granules, the alpha, and dense granules by an exocytic process. This provides a high local concentration of effector molecules essential for platelet plug formation at the site of vascular injury. For example, the aggregating agent ADP is released from the dense granules. Platelet activation stimulates the formation of another aggregating agent, thromboxane A2, abbreviated here as TXA2. via the arachidonic acid cascade. Details are shown in Figure 26.5. The most potent platelet aggregating agent, thrombin, shown here as factor 2A, is formed via the coagulation pathway from prothrombin, or factor 2, on the procoagulant surface of the activated platelet. Details are shown in Figure 26.6. ADP, thromboxane A2, and thrombin bind to specific platelet membrane receptors and stimulate aggregation on and around the platelets adherent to the subendothelium via receptor-mediated signal transduction events.
Pros and cons. Pros. The addiction of clopidogrel, a palliative P2G12 receptor agonist, produces even greater secondary prevention of coronary events in high-risk patients for up to 1 year. Cons. Drug toxicity may be incurable when multiple antipalliative drugs are used. Gastrointestinal bleeding is a common event seen in many patients.
Hey, this is Yogesh Reddy from AHA 2014. I'm here with Dr. Mori, who was the PI for the DAP trial, and she's going to give us the scoop on this trial. Dr. Mori, if you don't mind telling us, what were the aims and design of the trial?
Sure. Well, the study was designed in order to see how patients with coronary stents should be treated beyond 1 year, especially because we knew that there's some risk of stent thrombosis and, more importantly, a risk of recurrent myocardial infarction in the late future.
Excellent. And what were the results of the trial? What did you find?
So we enrolled 26,000 patients worldwide, and we randomized patients both with drug-eluting stents and bare metal stents to either continued thienopyridine plus aspirin versus aspirin alone. And the drugs that could have been used were clopidogrel or prasugrel, and there were multiple different stent types, including 50% of the stents, drug-eluting stents, were everolimus-eluting stents, so modern-day stents, so very relevant to current practice. And what we found was that in the patients who continued thienopyridine beyond 1 year, out to 30 months, that there was a very significant reduction in stent thrombosis, but more importantly, in myocardial infarction. So the rate of myocardial infarction was cut in half, and stent thrombosis was reduced to 1/3 of what it would have been without that in the patients that were on placebo.
So, we have a lot of trials now telling us about the data with 6 months, 12 months, and now this trial with extended follow-up for 30 months. So which patients do you think, for the fellows in training, who needs to be treated for 6 months, who needs to be treated for 12, and who needs to be treated for longer?
Yeah, so there is a lot of information about both these drugs and stents over the long term. There are patients that couldn't be enrolled in our trial because they had either had a heart attack during the first 12 months, after their stent procedure, and then they needed to restart the clock and take dual antiplatelet therapy, or others who had major bleeding and we didn't feel comfortable randomizing into the trial. So those sorts of patients, I think, you see how they're doing, and if they can't take it because they've had major problems with the drug, then obviously they're out. So, but what we found was that in those patients who hadn't had major bleeding or a major event within the first year, that even though there is a bleeding risk that's ongoing, that's probably counterbalanced by the benefits, because the benefits were so profound. It's a 2% absolute percentage point reduction in MI just over 18 months. And so that's even stronger than many of our secondary prevention trials, looking at statins and other things. So I think that this is just a new way of looking at secondary prevention.
Excellent. Thank you so much. So,
Used applied in Ecuador, the dual platelet is used in the myocardial infarction after putting a coronary stent and prevention of secondary
drug-eluting stent, dual antiplatelet therapy with a platelet P2Y12 receptor inhibitor plus aspirin is recommended for 6 months to 1 year. The risks and benefits of treatment beyond 1 year have remained uncertain. The recently completed DAPT study randomized 10,000 patients who had received an FDA-approved drug-eluting stent, had already completed 1 year of treatment with dual antiplatelet therapy without having ischemic events, repeat revascularizations, or major bleeding, and had shown a high degree of compliance with that year of therapy. The patients were randomized to receive an additional 18 months of either continued dual antiplatelet therapy with aspirin plus a thienopyridine, either clopidogrel or prasugrel, or with aspirin alone. The co-primary endpoints were the incidence of stent thrombosis and a composite of death, MI, or stroke. As compared with aspirin alone, dual antiplatelet therapy resulted in a 1% absolute risk reduction, a 71% relative risk reduction, in in-stent thrombosis, and a 1.6% absolute risk reduction, a 29% relative risk reduction, in major adverse cardiac and cerebrovascular events. The rate of moderate or severe bleeding was higher in the dual antiplatelet group. At the 33-month follow-up, all-cause mortality was 2.3% in the thienopyridine arm, as compared with 1.8% in the placebo arm. This appeared to be driven by a higher rate of non-cardiovascular death that was accounted for by differences in major trauma associated with bleeding and in cancer-related death. The central conclusions of the DAPT study were that dual antiplatelet therapy continued for an additional 18 months, reduced the risk of in-stent thrombosis and major adverse cardiac and cerebrovascular events, increased the risk of moderate or severe bleeding, and increased non-cardiovascular mortality. While it doesn't offer an easy answer, this much-awaited trial adds important data to inform individualized decisions about the optimal duration of dual antiplatelet therapy for patients with drug-eluting coronary stents.
Conclusion. Consent exists regarding the balance between reducing the risk of the cardiovascular events and the risk of bleeding complications, because bleeding complications are linked to aberrant autocognitive patients with acute coronary syndrome.